pleasure to be on this desk at JPAC. So I will be talking about difficult hilar dissection. He has given me the topic on this. So as we know that hilar dissection, as since morning we are seeing, it's a really important step whenever you do the nephrectomy. And generally single renal artery and vein is considered as anatomy, but it is not always. We found double renal artery in 20 to 30% cases, three renal artery in 1 to 2% cases, and sometimes we came across up to the 4 renal arteries. So I will be talking about to study the anatomy preoperatively before dissecting your gland and assess how difficult is preoperatively. It is important to assess which case is really difficult and what all instrument can help you dissect the hilum and how to reach safely up to the hilum, and then lumbar vein dissection, the multiple renal artery and renal vein anomaly, and sometimes the troubleshoot. So to see the anatomy is very important. Nowadays we have very good 3D and we can see what are the number of the arteries in the vein, what is the relation of the vein to the artery, and what are the accessory artery, then what is the lumen, then we really need to sacrifice or we have to preserve it, and what is the early branching, if there is a renal artery early branching, then we have to see how early and the late confluence of the renal vein. The right side if we have to take, then we have to really assess where is the IVC, because we see this, it's looking like 2, but once you will take the IVC here, it can become 3, or you have to dissect in between the aorta and the cable dissection. And then to look for the venous anomaly like retroaortic renal vein, 3 cable renal artery can be there on the right side, or the double IVC sometime, or the situs inversus. I will talk about this. So, which case you are really difficult to start? So, infected or pulmonary fertility, you can think of that they can have an erosion hilar. Xanthogranuloma pyelonephritis, large renal mass in which all the anatomy is distorted, and this is compressing of your renal vein or the artery. So, large renal mass are difficult to operate, and previously operated patients, or sometimes in the previously operated cases, we have the urinoma. So, there will be dense adhesion in the hilum that will be difficult to operate. Malrotated or the horseshoe kidney, and to me, the simple nephrectomy is most of the time is not simple. We call it as a simple nephrectomy. So, what all instrument we have discussed? Energy source, suction is my one of the favorite instrument when we do the dissection. Mainline dissector, right angle dissector, clips, wet clips, 5 mm, 10 mm, giga clips, or statistic clamp for your safeguard you if you have any problem. So, how to reach safely? So, it's very important to dissect the bowel appropriately, the plane in the morning we have seen, and then to lift the urotogonadal packet so that this is your guide that you can reach to the hilum. It's very important to see lift the urotogonadal packet adequately, and that is a guide to reach to your hilum. Once you are reached to the hilum, the first thing on the left side you came across is the lumbar vein. Since in the morning we have not seen any patient who is having lumbar vein, but it is very common finding. So lumbar vein are really covering your renal artery. So it's like a bodyguard. Until unless you will dissect the lumbar vein, you will not be able to see the renal artery most of the time. So now you see this is the anatomy, but you can get the variation of the lumbar vein. This lumbar vein is the state 1. So I always dissect gently, and because once it starts bleeding, so it may get retract or it can lead to difficulty in dissecting further. So you dissect it, and I always clipped it. So previously you have seen someone that who is doing with energy source, but I really prefer to clip it by, and then in between you have to cut it sharply. I don't use harmonic in between because otherwise the stump will be get damaged. So it's important. And now this is another variation where you can see small renal lumbar vein, and then it's bifurcated. So you have to be very gentle when you are dissecting the lumbar vein, otherwise it can lead to the bleeding. And then you come across the multiple renal artery. So this is the renal artery, and here whatever you will do is avoid any energy source near to the renal artery if you have to like donor nephrectomy, otherwise you can go ahead. And now you see you have to have double clip and cut, and there has to be, you have to hear the sound of the click, and you have to keep some space before cutting to the renal artery. And this is the case of early branching, and which is supplying to the lower cone. And once you reach there, then because when you will apply the clip, it will become 2. So that you have to assess preoperatively, and because it's going to the lower cone, then you have to save if you are doing the non-linear nephrectomy. And this looks like very early branching, but now you see when we dissected it appropriately, you can see that you can get this good stump. So you can apply the 2 back clip easily, because in the preoperatively you see that it was very short stump, and you can apply the 2 back clip here, and then you can cut and you can get the common stump, and there is no need to do the bank surgery. And sometimes you came across 3 renal artery. Practically it is a 2, but it's very early branching, the upper one, and finally it will be, once you will apply the clip, it will become the 3 renal artery. So pre-operatively CT angio to read and to assess that where you have to do and how it is going to affect your surgery, you have to be very sure before proceeding. And finally, these are the 3 renal artery that you have to do the bell surgery and you have to reconstruct. This is again 3 renal artery. Here it is important to see because the lower pole artery is very far away from the hilum. So once you are lifting the urotomonadal packet, you have to be very gentle because this is the lower polar artery which is very far away from the hilum. So you have to be very cautious when you are dissecting it because otherwise it can be damaged or you can unnecessarily coagulate it or clip it. So you have to know the anatomy because it is going very far away from the hilum. So once you will start lifting the urotomonadal packet, you have to be very cautious and then only you will be able to save this part. And it was bilateral triple renal artery. So here you can see all is completely dissected. And this is 4 renal artery. From the CT angio it looks like 3 renal artery, but once you will go and see the other planes, it is very early branching on the upper side. So this is the smaller one, the lower one, and finally we get the 4 renal artery for the transplant. So after this we get right side. There is a different anomaly like double renal vein, and normally in the right side we get the renal artery which is retrocaval, but sometimes pre-caval. So this is a pre-caval renal artery at the lower pole, so you have to dissect it, and it is a double renal artery, double renal vein, and finally you can get with this clip and you can manage it. And these are the some anomalies like double IVC. You have to be known this as anatomy because you can't think it is like a large lumbar vein. So it's simple like that. It is happening onto the right side, but it is a double IVC. So you have to be very conscious and you have to clip your renal vein as you do on the right side. And sometime you came across this kind of the. So this is previously operated patient. It's really difficult to assess its lust, and then to get the access it's difficult. Then to dissect it's again a problem. And but with experience and with all your precaution, you can reach to the hilum and you can really dissect where is the renal artery and the vein. So these are troubleshooting. I will be just skip because of the time. So you can, but main important thing is whenever you have a bleeding, just pack it and wait for some time, and then you can have an extra help or extra port, and that will help you. Thank you. So with JPAC enter to learn and to serve. Thank you.